So for those of you who don't know myself, I am a GP by background. I'm a portfolio GP. Portfolio GP essentially means a GP that does other things on the side. So general practice, one of the main advantages is that you're not always in a full-time role. You can kind of create your week as you like. And I'll talk about that in a second. But now I'm full-time in medical education, but my job before that was working in general practice. I'm a fellow with the Royal College of GPs as well. And like I said, I've had lots of previous roles, whether it be examining or assessing or training or setting exams, for example, through many different exams, mainly throughout GP training. That's a bit about myself. So the talk about this coming out now is a bit about what is general practice, just to give you an idea about how the system works in the UK from a primary care and secondary care point of view. Some of the pros and cons are things that I often hear as benefits, and some of the things that I often hear as cons, and talking about those a little bit, talking about the application process for general practice and what that's all about, and then talking about the assessments that you need to do, i.e. the MSRA assessment coming up. And while we're doing this, if Dr. Pooja can put some of the key dates for application that are coming up in the next couple of months, that would be useful. The date for application, the date for the MSRA exam, and the dates for starting. Then you guys can kind of bear that in mind when we're going through this talk. So what is general practice? So in essence, in the UK, of course, as you guys probably know, we have a primary care system, which is basically general practice, the community side of medicine, and then a secondary care system. Now, unlike lots of other countries, the bulk of medicine in the UK is done in primary care. So I forget the figure, it changes, but a significant proportion, or the majority of day-to-day consultations between patient and doctor happens in the primary care system in GP practices, general practices. And then they're almost a gatekeeper, almost seen as the gateway of the NHS. So a lot of things that can't be handled in general practice, say 90% can be handled in general practice, whereas maybe 10-12% might need to be referred to secondary care, to consultants in hospital, to specialties, and the NHS has this gateway system where referrals are done from primary care into specialty secondary care, whereas in other parts of the world, a lot of patients may go direct to secondary care. They'll go directly to a cardiologist or directly to a renal physician, whereas in the UK, it's the GPs that see the bulk of medicine, and only some of those, a small percentage, go into secondary care. So like I said, the bulk of UK doctor consultations are in general practice, and the bulk of doctors in the UK are GPs. Because of that need for that system to work effectively, the majority will end up in general practice. So there's a shifting term now from a GP to the change in terminology, so consultant family physician or a consultant generalist. So there's a big shift in terms of, because people often used to say, oh, it's only GP, it's only a GP, whereas now, because general practice is so complex and it covers such a wide range of presentations in medicine, the terminology is now rightfully changing into consultant generalist or consultant family physician. And the other main thing to remember when it comes to general practice is that GP surgeries or GP clinics are in essence independent businesses. So they're all connected to the NHS, but they work as an independent business, and then GPs own that business or can hire other GPs and other staff to work in that business itself, and then you're contracted to the NHS as an individual business. So that's how you kind of get paid as a GP surgery, and then you get paid as a GP in general. We have a couple of blogs on how the financial system works in general practice, which you can find on the website. So that's a bit about what general practice is and who GPs are. What are the pros of general practice? A lot of doctors do end up in general practice, and a lot of doctors who don't think they will end up in general practice eventually do decide to go into general practice, because once they start working in the UK, they start to understand a little bit more about what general practice is all about, and they see some of the potential pros that link in with their plans going forward. So unless you have a burning desire to be a consultant orthopedic surgeon or a burning desire to be a cardiologist, you may well have to think about at some point a career in general practice because of some of the pros that might be there. So flexibility is a really big one. As I was a portfolio GP, that meant I was doing certain amounts of clinics in a week, and I had time to develop other things. Now, you can develop other things within medicine itself. So, for example, you could become a GP with a specialist interest in pediatrics, or a GP with a specialist interest in women's health, or a GP with a specialist interest in minor surgery, for example. So you could have a kind of dual career where you do half the week in GP and half the week doing something that you have a real specialty preference for. Or you could do something completely out of general practice. So there are lots of GPs who do half the week clinical work, but then they might do half the week in medical politics, or half the week in medical education, or half the week in property development, whatever it might be. It gives you the flexibility. Now, a lot of GPs also may say, well, I just like general practice. I want to do 5 days a week of general practice, or 6 days a week if you want to do weekends. So you can do that as well. But the flexibility of having choice that's found in general practice is found in very few other specialties in the UK, because once you're a consultant in a particular field, you're dictated to by needs of the trust, needs of the hospital, rotas, for example, and so you get that little bit less flexibility. Whereas as a GP, you can pretty much plan your week as you like it. Range of medicine, again, unless you're a born orthopedic surgeon, vascular surgeon, radiologist, for example, and you want to just do pure medicine, then you've got a couple of options. You've got acute medicine in hospital, so an acute medicine consultant. You could do A&E, because you could argue you're going to see a range of medicine in A&E, or you could do general practice, because in general practice, you get literally you're helping people from cradle to birth, from birth to the end point. So you're seeing babies 1 or 2 days old, and you're seeing people who are 100 years plus. You have no idea what's coming in the door next. You get to know families, you get to know how dynamics work within a particular a family or an area or something like that. But the range of what you see is something that attracts a lot of people to general practice. You have no idea. Your medicine has to be to a pretty high level because of the amount of things that you see. And like we said, around maybe 10% of things that you see as a GP, you need to refer on to specialty. That shows you just how much medicine is covered in general practice. It could be chronic conditions that you're continuing to care for a long period of time, diabetes, hypertension, atrial fibrillation. You're following people up for a number of years and keeping their condition under wraps. It might be an acute presentation that presents you for the first time, a suspected meningitis in a 3-year-old, and you've got to urgently act and get them into the relevant places. Or it could be a more kind of non-specific presentation, a vague presentation where someone comes in with very non-specific symptoms, and you're taking time to understand how these potentially could play out from a clinical point of view and what conditions and what investigations to arrange, but also thinking about the psychosocial aspect and how other things may be linking in with their presentation. So it's such a broad range of medicine, and if your interest is medicine as a whole, then general practice may be a strong thought for you. Continuity of care, there's very few specialties in medicine now where you see people throughout the whole journey. So as a GP, you get the privilege of seeing somebody potentially right from the beginning of their presentation, through all the initial investigations, through looking at differentials, through thinking about managers, and following them throughout the next maybe 5 or 10 years. Even if they're referred to a consultant for a particular condition, you still have that overall idea of continuity of care. So this principle that you can see somebody through a journey and see potentially to the end point is quite a rewarding one for a lot of people. And patients like to have that continuity, see the same doctor for the same problem over a long period of time, as well as seeing them for other problems as well. Like we mentioned, you can choose your working time. So some GPs will only work afternoons, some GPs will only work mornings, some GPs will only work on weekends. You can be a little bit flexible. It goes back to that flexibility factor that people often think of as a strong pro for general practice. So you may not be able to choose your exact clinic times, but you can choose a lot about when you'd like to work, whether it be days of the week or times of the day. And then, like we said, one of the big pros of general practice is the fact that you may have time to do other things, either in the medicine field or the non-medicine field, because you have the flexibility to create your own week. So some of the pros are out there for everybody to see, and it's worth understanding some of those. And these are some of the reasons why a lot of people do end up going into general practice, perhaps if they weren't even thinking about it before they came to the UK. What are some of the cons that you may hear about of general practice? Oh, you don't want to be a GP because of this, or why do you want to be a GP because this might happen? You're going to hear lots of these, but they may all be perceived cons, and there's lots of talk sometimes where these are over talked about. Is there a worry that you might miss acute work? Of course, if you like that hustle and bustle of working in an emergency department or working on acute medical on-calls, then yes, there's an argument to say you're not going to see as much of that in general practice. But remember, a lot of acutely unwell patients will go to their GP first. So you will be seeing acute presentations. You can just do, for example, out-of-hours work where you just only see acute presentations. So yes, you can argue that you're going to see less of the higher end acute medicine. So if that is your preference, then maybe it may not be for you, but you still will see a lot of acute presentations in general practice. It's not something that you will not see at all. Some people talk about loneliness. They worry about missing the bustle of the hospital environment, working on wards, working in teams. Now, for those of you who don't know too much about general practice, most GPs now, most general practices are huge organizations in themselves. They may have 10, 12, 20 different doctors, nurses, pharmacists, physician associates working in the same practice. So you develop a team within your surgery and your practice, and therefore loneliness is much less of a problem now that it may have been, say, 10, 15 years ago when there was lots of single-handed GPs, much smaller individual units. And yes, there was a lot of people there who did get lonely because you were working in your own clinic day in, day out, and you had little interaction with the rest of the clinical world. That is not really the case now. Most general practices are big super hubs, and there are lots and lots of doctors and nurses and other allied healthcare professionals working in the same team. So this is less of a con now. So this worry that people often have is probably much less than it was 15, 20 years ago. People sometimes think about the responsibility. Yes, at the times, you are the individual seeing that patient, and you need to make decisions about care that could have lots of implications. Whereas some people feel that when you're working in a hospital environment, you have a whole team around you all the time, and you can easily take that shared responsibility for a patient. Again, like you mentioned, nowadays, in these big kind of multi-organization general practices, there are lots of people around. So that responsibility of it being all on you is not there like it used to be maybe 10, 15 years ago. So this possible con that people often worry about, I'm on my own on a Friday evening in a building, a patient comes in very unwell, what if I don't know what to do? That is much less a case now than it used to be maybe 5, 10 years ago. So it's worth bearing that in mind. People worry about becoming de-skilled. So, for example, if you're not doing the chest strains on a daily basis, you're not doing your ascitic taps on a daily basis. So people think that if you're in general practice, you may get de-skilled. And to a point, that is true. You're not going to do those certain procedures that you'd be doing in hospital settings, but you can develop lots of other skills that you can do in GP land. If you become a GP in a specialist interest in ENT, for example, you will get used to doing all of your ENT procedures. If you become a GP with a specialist interest in minor surgery, you will be doing lots of minor surgery that doesn't reach the hospital setting. So in a way, you could argue that you get de-skilled from certain procedures, but then you can develop very specialized skill sets in others, depending on areas that you want to work in. So the argument of being de-skilled, again, is perhaps one that was a more high value 10, 15 years ago, whereas now, where a lot of GPs are becoming GPs with specialist interest in something else, this de-skilled factor may be less of something to think about. And the final thing that we often hear is that, oh, in general practice, all you see is costs and calls. All you see is the kind of very simple, you don't really get to do any medicine. Again, very, very untrue. 90% of the consultations and the medical care, potentially in the UK, are done in the setting of general practice. You need to know your medicine inside out. You need to know when somebody comes in with a sore throat, could potentially have a very worrying presentation like epiglottitis or something like that you need to act on. It's not just seeing coughs and colds, you're seeing the whole range of medicine. Yes, you are going to see some trivial presentations that you don't need to worry about, but the skill is in looking to see how you pick up the ones that are the ones that you need to be thinking about, and that is a skill in itself. So you're not just seeing coughs and colds, you're seeing a huge amount, including acute work, chronic disease, and continuity of care. So the cons, yes, you may see them as cons, but when you look into them in a bit more detail, the things that you hear are not as they perhaps were in the past when it came to general practice. So my own GP journey then, so I was born in the UK. My father was a GP in the UK as well. He trained in India. He came with plans to do psychiatry and become a consultant in the UK, but he ended up being a GP. He wasn't a person who wanted to do GP. He kind of became a GP because that's what a lot of people did at that time. But in the end, I think he really enjoyed the fact that he was seeing a wide variety of clinical presentations. So cardiologists and psychiatrists were his two things. And I took on that cardiologist view as well. So when I was in medical school, I wanted to be a cardiologist. I didn't even think about general practice. It wasn't in my mind. I'd seen my father be a GP, but it wasn't really for me. So I completed medical school in 2005, did foundation year 1, foundation year 2, and at this point, I saw the benefits of GP training. So I did some GP jobs as a foundation year doctor. So I did my FY2 rotations, and one of those was in general practice. And that's when I really got to understand some of those pros that I talked about earlier on. And I got to realize that the cons that I'd been hearing quite a lot by other people were not really cons in themselves. So I applied for GP training and did the GP training scheme between 2007 and 2010. And I'll talk about the applications with GP training and how you do that in a second. And then since then, like I mentioned, I've had lots of clinical and education roles, mainly around general practice, so GP training, helping other trainees get through GP training themselves, appraising other GPs, and also then getting involved in full-time medicine in 2018. So I have been a GP, I've seen the pros of it, and some of the cons that I'd heard before, certainly when they came across and I actually did the job itself, I realized it was far from what I was hearing in the earlier parts of my medical career. So what are the basics of GP training in the UK then? So a minimum of 3 years specialty training as a GP specialty trainee. So you may hear of other specialties where you have 7, 8 years in training. GP, one of the reasons a lot of people do general practice is because of the shorter training program, 3 years as opposed to 7 or 8 years, and you'll come out as a fully qualified GP with MRCGP. This is now changed to 4 years in certain schemes, because 3 years, to be honest, is not enough. You can't, the 3-year system was developed for the 1980s, but now it's moved on. The complexity of general practice is so much more that you'll see many, many more programs become 4 years over time. But still, the minimum that you need to do is 3 years. Usually 18 months of those 3 years you're working in a GP practice itself, probably split between 2 practices, so 6 months as part of your 2nd year in one practice, and the whole of your 3rd year is in one general practice. And the other 18 months, and in some areas it's more than that, it's less and more than that, but generally the other bits of work that you do outside of GP training, you're spending in various hospital rotations, and you're doing hospital rotations that are linked to general practice. So you may be doing pediatrics, you may be doing obstetrics and gynecology, you may be doing ENT, things that you are building up experience in because you're going to see a lot of those things in general practice. So those 3 years are split between hospital jobs and GP jobs, with the overall aim of maximizing your ability to work as a GP. Every year you need to clear a certain point. It's called an ARCP. We'll talk about this in a second, but every year you need to be almost ticked off. So to go from year 1 to year 2, to go from year 2 to year 3, and then to end at year 3. By the end of GP training, you must complete MRCGP. It's the only specialty in the UK, or one of the only specialties in the UK, where you must get your MRC in order to complete training. There are lots of other specialties where you can work in the field without having MRC, but you cannot work as a GP in the UK without having MRCGP. So your MRCGP assessments are built into your training program. So you take assessments to get into training, and then you've got to complete MRCGP by the time you come out of training. And at the end, as long as you've A, got MRCGP, but B, ticked off all the other boxes that you need to tick off throughout training, getting certain things signed off, for example, you will end up with a certificate of completion of training, and then you are an independent GP, and you can make decisions as to where you want to work, how you want to work, and how you want to develop your career going forward. So the 3-year pathway then, GPST1, GPST2, GPST3, there are some 4-year programs now as well. So generally 3 years, there are 2 main exams you need to cover as part of MRCGP. There is the AKT exam, the Applied Knowledge Test. This is an MCQ-based exam that you can do in various parts of the UK. And then you have currently the RCA, the MRCGP RCA. It used to be the MRCGP CSA exam, where you went to the main RCGP centre in London and did an OSCE exam, whereas now since COVID, there's an RCA assessment where you record real-life consultations in your practice and have those assessed. This will probably change in the next couple of years to something new, but it's still going to stay the case that you need to do 2 major exams in GP training, your AKT exam and then your RCA stroke, whatever's coming left. And every 6 months, you have what we call an ESR, an educational supervisor review. So you have one person that is your mentor, if you like, throughout your whole 3 years. And every 6 years, you have a review with that GP. And then, like I said, at the end of every year, you need to clear an ARCP, an annual review of competency progression, to make sure you can jump into the next step. So what's the eligibility criteria then if you want to apply for GP training in the UK? So there's a number of things that you need to make sure you have in place in order to actually apply in the first place. So you need MBBS or equivalent degree, you need to be eligible for full registration and hold a license to practice from the GMC at the time of intended start date. So remember, you apply quite far in advance when it comes to GP training. You need evidence of achievement of foundation competencies in the 3.5 years preceding the start date of your training. Now, this is similar to other specialties. We've talked about things and methods to demonstrate evidence of having competency. You could be currently in a UK foundation program. You could have previously completed a UK foundation program within 3.5 years of that start date. You could currently be employed in a specialty training program. So a lot of people start training programs in certain fields, whether it be pediatrics or radiology, and then they want to transfer into GP training. So again, you need to demonstrate that you have the competencies, but the commonest way that people will do it as an IMG doctor is using the CREST form that has been talked about in a number of other talks already today. So the certificate of readiness to enter specialty training. The current latest version is the 2021 version. There's not been a 2022 version yet. There may well be, but this basically needs to be signed by a consultant either in the UK or abroad to demonstrate that you have these foundation competencies to allow you to apply to GP training. You need at least 2 years clinical experience by the time training starts. That could be a mix of training back home, it could be a mix of training in the UK. You need to be eligible to work in the UK in general, so not as a clinician, just generally need to be eligible to work in the UK, and you need a UK driving license or equivalent transport arrangement. It's the one specialty where this is part of your criteria, because in general practice, you will be doing home visits. You'll be traveling to people's houses to assess them at home, and you need some kind of evidence to show that I can do this when I'm working as a GP trainee. So either your own license, or you will say that I'll take taxis every day, or whatever it might be, to get to those certain home visit assessments. So I'm just checking if Dr. Pooja's put the relevant links of the time dates yet. Yes, she has. Great. She's put the dates in the chat. So in terms of application for GP training, there are 2 rounds every year. There used to be 3 rounds, or one of the rounds was split into two parts, but the latest few years has been 2 rounds, August and February start. So those aiming to start in August, so for example, August 2023, or there's another round for those starting kind of at the halfway point, so February every year. So the bulk of people apply to start in August, because the majority of people ending foundation year training will be in August, but then there are some seats available for a February start as well, so the 6-month gap. Application is coordinated by the GPNRO, the GP National Recruitment Office. You can have a look at their website. It goes through things in detail there. The process allows a candidate to demonstrate abilities and suitability for GP training. So the whole point of assessing you at this point is to see, do you have the skills, the abilities, the suitability to be able to come out of GP training in 3 or 4 years' time. So they're almost assessing the skills that you have now to see, are you trainable to come out as a GP? So they're not looking for you to be a GP at this point, of course, but they need to look for certain abilities and skills that tell you that it's likely that if you start the program, you will finish the program. And they've done a lot of research on this, and the assessments are based on these things to try and look for these things early on. Application to the Oriel recruitment portal using the electronic application form. We do have a blog about how to get into GP training in the UK. Hopefully Pooja's going to put that out at some point. So it's just, the blog is all about this process in much more detail. So make sure you have a look at that blog when she puts it in the chat. So you apply through the Oriel recruitment portal using electronic application form, and at application, you rank your preferences from all the different GP programs around the UK. So you have West Midlands, East Midlands, North, Pennine, etc., and you rank your preference as to where you'd like to work ideally, and then you rank it all the way down to the bottom. But you don't have to put every area, so you would only rank areas that you want to work. So for example, if you said, I only want to work if I get GP training in West Midlands or East Midlands, then you just put West Midlands or East Midlands. So, but most people tend to put quite a few areas unless they really want to work in a specific area. Once the application window closes, you're invited to register with Pearson VUE. Pearson VUE is the area where you'll take the MSRA assessment. So as long as you've done the application, as long as everything has been checked that you are okay to apply for GP training, then you get invited to register with Pearson VUE. And if everything is okay and you've got your registration, then at that point you're invited to sit the MSRA. So the MSRA assessment can only be done if you've cleared all the eligibility criteria and your application goes through successfully. Once you've hit that, then you're invited to take the MSRA exam at one of the Pearson VUE centers. A computer-based exam, and you go to a certain place to do that exam. So a bit about the MSRA then. It's a computer-based exam, like we mentioned, taken at Pearson VUE test centers. It assesses various competencies, and those competencies are outlined in the person specification document. So if you're looking to see what are the kind of things that they're testing me on, there's a person specification document in the GPNRO website, the GP National Recruitment Office website. It's worth looking at that. The MSRA consists of 2 different papers. You take them on the same day, but 2 different papers. One is a professional dilemma paper. This is where you have 50 SJT questions, situational judgment tests. So they're not testing clinical knowledge here, they're testing your ability to rank or decide on appropriate action in certain non-clinical situations. So for example, you're in a ward round and one of the registrars gets angry and shouts at one of the junior doctors or the medical student. How do you approach that situation? So it's nothing to do with clinical, it's about understanding things like the GMC good medical practice. So that is your professional dilemma paper. And then you have a clinical problem solving paper as well, 97 questions. These are quite your more traditional clinical based questions that you guys will be used to doing throughout medical school and throughout your early parts of training for other exams. So 2 different papers make up the MSRA. A lot of people neglect the clinical paper because they're focused so much on the professional dilemma paper. So you've got to make sure you're still staying up to date with local UK guidelines, understanding NICE, understanding how to do investigations and how to treat. But then you've also got to make sure you're spending a bit of time practicing SJT questions and understanding techniques around these things, because this is an exam that's very different to one that you may have done before, and a lot of people will fall down on SJT papers as well. So we do a lot of work for these two papers. I'll show you the resource that we have in a second. Total duration is around 3 hours. There's no pass mark, so it's not that if you get above 80%, you get into training. There's no kind of maximum score that you need or minimum score that you need. It's all based on rank. So it's a competitive exam. So everything in terms of GP training is based on your MSRA score. You've heard of other specialties talked about today where MSRA might be part of a whole process. They look at MSRA plus interview plus, an OSCE, for example. Whereas for GP training, it's all based on MSRA. So the better you do, the higher rank you get, and therefore more likely that you're going to get offers for jobs that you want in areas that you want, rather than if you rank low and either may not get an offer at all or get an offer in a place that you put down but you didn't really want to travel that far. So doing well in MSRA is paramount to doing well and getting the job that you want or the training position that you want in general practice. So when it comes to MSRA approach, and the next MSRA is in September this year, so a lot of you guys might be preparing for September MSRA already, or you may be thinking of the next year or the one after that. But a couple of things are worth bearing in mind when you start approaching for MSRA. Number one, you've got to do a dual-based approach. What I see often people doing is just doing questions. And of course, questions are good. You have to do regular questions to get your brain used to the style of question, to learn about problem solving. But you need to be boosting your knowledge base as well. You need a questions-based approach and a knowledge-based approach. The knowledge can be clinical, so going through guidelines, going through material that teaches you that, but knowledge is also for your other SJT paper, reading through things like good medical practice, making sure you understand ethics around medicine. So you can't just rely on questions. You need this dual-based approach where you're doing questions plus knowledge. Second, you've got to aim high. Like we mentioned, this is not a pass or fail. Don't aim to pass. Aim to try and hit 100%, because this is a competitive exam. The higher the score you get, the more chance you're going to get a rotation that you want. So you've got to aim for the top. And that means trying to fight for every mark and learning not just the knowledge, but also technique as well. Which question bank? We often get asked, which is the best question bank for MSRA? There isn't really a best question bank. It's more about which resonates with you. But the one that you need to find has got to teach you about two things. It's got to teach you knowledge, but it's got to teach you technique as well. There's no just point doing question banks that teach you a whole lot of knowledge if you're not picking up technique gaps. So all of the question banks that we do, the mocks, for example, they look to test on both knowledge and on technique, because that technique side is so big when it comes to MSRA. And also, don't study alone. It can be quite a long exam, particularly when you're going through SJT questions. They're quite long. There's quite a lot to understand. It can be quite lonely. It can be quite tedious. Try and find a buddy. Try and find somebody else who's applying for MSRA. On our GP training support group that we put the link out for on Facebook, just put a message out there. Anyone preparing for MSRA, anyone want to do studying together, you often find little groups that can work very well. So when you come to MSRA, if you're preparing right now, hopefully things are going to help, because just doing lots and lots of questions and hoping that you get a good score in MSRA doesn't really work. I've seen it too many times. So what are the kind of things that we can do in terms of helping for MSRA before we move on to the next part of this talk? MSRA Gold Package is our most common and most comprehensive bundle that we have for MSRA. Essentially, it's 5 or 6 different things in one package to try and help with both the knowledge side of things, but also the technique side of things as well. So it's got a full clinical crammer online course, a video-based course that you can pause. We'll go back to. It's chapter-based. It's based on the syllabus that you need for MSRA. We have currently 14 full MSRA mock exams, 7 clinical exams, and 7 SJT exams. We've got 2 sets of digital flashcards, 1 clinical guideline-based flashcards and 1 pharmacology-based flashcards. And we have 2 audiobooks which buy you time, a clinical audiobook crammer and an SJT principal audiobook as well. So all of this comes as part of the MSRA Gold Pass package. Remember, that's 15% off the already saved amount that you get from the package using CompSave today. So that's the Gold package. You can buy any of these individually as well, but if you're looking for that knowledge plus technique approach, then it's the Gold package that you're really looking for. And this is a 12-month access package. So whether you're doing the exam in September or whether you're doing it next year, you have 12 months of unlimited access. You can use these things as many times as you like in that time period. I think Dr. Pooja is going to put a link for the MSRA Gold package up in a second. We do a lot of work on social media. It's great to see a lot of you guys have joined us on Instagram today. If you are on Instagram, please do have a look at us. We do loads of free teaching, not just for MSRA, but PLAB 1, PLAB 2, medical exams as well, medical school exams, Dr._Aman Arora. We teach by images and pictures, and a lot of you guys learn like that. If you're on YouTube, have a look at our channel. We have lots of teaching of short, sharp, clinical-based videos on YouTube that you may find useful. And as mentioned, we have our Facebook GP training support group. If you're thinking about GP in the future, then please do join this training support group, because we will keep you up to date on things like when to apply, what stages you have application, what are the ways to prepare. And if you're on Twitter, then again, it'd be great to see you on Twitter. But Instagram and YouTube are the two that we do a lot of work on, and it's worth having a look at those. You can unsubscribe if you don't like it, but let us try. Have a look at in fact, get your phone out right now, have a look at Instagram and see if you resonate with the type of teaching that we might do. So some take-home message before we go for a really quick break then, and some lunch. GP is very, very popular. Okay, lots of people do apply for GP, both those that want to really do GP, but also those who are kind of applying for GP as a side thing, and also applying for other specialties. Plenty of pros and cons. Definitely lots of pros of general practice. There are cons as well, but you've got to look at it in that perceived light that we talked about earlier on. The cons that often seem cons are not really cons in modern day general practice. Perhaps they were in the past. You've got to know the application process and know what stages you need to achieve, what's the eligibility criteria, and it's worth going through that blog that we put up as well. I don't know if you've got that blog. Let's just double check if Dr. Pooja put that blog up. So we have a blog on how to get into GP training. Yeah, she's put that blog up actually, so you can scroll up the chat and have a look for that, and make sure you look at the MSRA, because that's the assessment that you need to crack to get a high score. And remember, it's a competitive exam, so it's not a pass or fail. You need to fight for every single mark. So before we go into break, if you're not preparing for MSRA, if you're preparing for PLAB 2, we also have a similar gold package for PLAB 2 that it contains our live role play course, online course, flashcards, audiobooks. And if you're doing PLAB 1 right now, we also have a PLAB 1 gold package that contains an online course, mock exams, flashcards, and audiobooks as well. So whether you're on PLAB 2 or PLAB 1, the conference coupon will still work today, CONFSAVE, CONFSAVE. I know a lot of you guys have already taken advantage of using this coupon today, which is great.